Greetings, my name is Ed McCutcheon, and today I will be discussing central venous catheter placement. Here today I'm going to talk about the indications and the contraindications and the risks and complications that you may encounter with central venous catheter placement. The indications for central venous catheter placement are the inability to obtain peripheral IV access, the necessity to administer IV medications requiring central venous access, such as pressors, as well as potentially putting in transvenous pacers and dialysis catheters. The relative contraindications for central venous placement include a patient that may be coagulopathic or severely thrombocytopenic. Also, if there's any anatomical disfigurement in the area that you may be considering to place your central venous catheter. So there are 3 sites that we can consider when we place a central venous catheter. The most common site that we use is the internal jugular vein, as well as the subclavian vein and the femoral vein. We'll start off by discussing the internal jugular vein. Today we're going to talk about the anatomical landmarks. Most commonly now, the internal vein catheter placement is utilized with ultrasound, but we're going to strictly use our landmarks for placement. So we'll start off with internal jugular vein anatomy. I'm right-handed, and most folks that are right-handed will approach a patient on the right side. What I typically do is position my patient where I can actually visualize the anatomy well. When I look at the anatomy, I am going to be visualizing the 2 muscle bellies of the sternocleidomastoid muscle, the medial aspect here, the lateral aspect of the triangle, and then the inferior aspect, which is created by the clavicle. And if you imagine this triangle, you're going to palpate the internal carotid, and just lateral to that and at the apex of the triangle is the entry point where you will be introducing your introducer needle to identify your internal jugular vein. With the use of ultrasound, this is a lot easier because you can visualize exactly where you're going to be placing your needle, but since we don't have ultrasound, we are going to rely on our anatomical landmarks. Some of the things you need to realize with the internal jugular catheter placement are the risks for complications. As with any central line placement, the risk is obviously infection at the site. You can also cause complications such as a pneumothorax, since it's very close to the apex of the lung. Some of the other long-term complications include venous thrombosis, and as well as complications with the central venous catheter equipment, where you could have potentially an arterial injury from the dilator. You could also have loss of your guide wire. So you want to be very careful when you do place a central venous catheter, as well as you want to be knowledgeable of the potential complications that you may encounter. So moving on, we'll talk about the subclavian placement. Once again, this is a blind approach, which everything is based upon anatomical landmarks. What I like to do is identify the sternal notch, as well as the distal end of the clavicle. And with my left hand, I am also palpating along the clavicle, and I'm feeling for the angle of the clavicle. And just below it, I'm going to take my introducer needle and I'm going to slowly march it underneath the clavicle and keeping it parallel. And I'm going to aim towards the sternal notch as I introduce my introducer needle, as well I'm gently aspirating to identify dark venous blood that is aspirated. And this would confirm placement of my introducer needle into the subclavian vein. Some of the things you need to be concerned about with subclavian venous catheter placement: one is, if you do hit the subclavian artery, you're unable to control hemorrhaging. Thus, it's not a desirable line placement if you have a patient that is coagulopathic. There's also the risk, especially in older patients that are cachectic, as well as smokers, you're at greater risk of causing an iatrogenic pneumothorax. So subclavian placement is a good placement if you're considering putting in a central venous catheter in trauma patients, especially if you do have a trauma patient that may have a pneumothorax on either the left or right side. You don't have to worry about causing an iatrogenic pneumothorax, and that essentially eliminates the risk for that. So I tend to do subclavian venous catheter placements in my trauma patients that may have a pneumothorax on the ipsilateral side. Same risk with that. You can develop infection. You can also cause a pneumothorax. Long-term use, you can also cause venous thrombosis, as well as I mentioned earlier, the potential for hemorrhage is also a risk. So in conclusion, with our internal jugular vein as well as our subclavian vein central catheter placement, to summarize the complications that you may encounter with these, both of them are at risk for arrhythmia. So when you do place your central venous catheter wire, you want to be cautious of introducing it too far, causing arrhythmia and irritation of the cardiac muscle. You also want to be cautious of air emboli. So when you do place these, make sure that you take caution in closing all your ports and preventing any air entry into the venous system. And both also have the risk for infection, and both have the risk for deep venous thrombosis. And this concludes the complications of the IJ as well as the subclavian. So what we have here today is a standard central venous catheter kit. You want to become very familiar with what's in your catheter kit, because the standardization is pretty much the same, but you may have different types of catheters. Today in particular, we're going to be using what's called a triple lumen catheter. And the way we can identify that is there's 3 lumen catheters attached to the central venous catheter. And you may also occasionally see what's called a quad lumen. You may also see what's called a large bore cordis, or also known as an introducer, which would be more for high volume resuscitation. But with a triple lumen or quad lumen, you would typically use this to administer multiple medications as well as fluids and potentially blood. One thing of note, so if you do have 2 good peripheral IVs, large bore, either 14 or 16 gauge, please realize that the same amount of fluid or more can be administered through peripheral IVs rather than a central line. So keep that in mind if you are simply resuscitating a patient with fluids. So I'm going to go through the equipment that we have here. So every central line kit has the standard equipment. You're going to have gauze, you're going to have your zero silk suture, your needle driver. You're also going to have your syringe and 27 gauge needle to provide local anesthesia before you make your or begin your procedure. There's also going to be 2 different types of slip tip syringes. There's one that has a guide where you can actually place your guide wire through, and it goes in through the syringe. There's also what most folks typically use. It's called a slip tip syringe, as well as an 18 gauge standard introducer needle. And this is the needle that you would typically use to locate your vein and introduce your guide wire. This is your standard guide wire. As you can see, the tip is curved, and what you want to do is make sure that it's just preloaded so that it's not protruding out. And you want to make sure that this is easily advanceable with your thumb. You're also going to have your scalpel, which is a standard number 11 blade. You're going to have your dilator. And you're also going to have, on some prepackaged kits, you're going to have syringes with your sterile saline. So the first step, obviously, you're going to make sure that you're in your standard universal precautions. So to minimize the risk for infection, you're going to wear your hood, mask, sterile gloves, and gown. And then you're going to also prep your area, whether you're using betadine or chlorhexidine. You want to make sure you prep your area well. For educational purposes today, we're going to go ahead and perform a right femoral vein central venous catheter placement. So what we would typically do is prep the femoral groin region, where we're going to show you the landmarks and identify what approach you would take when you're going to be placing your central line. The next step after your prep and after your drape and using sterile precautions, you're going to go ahead and load up your lidocaine, typically 5 to 10 cc's is all you need, especially in an awake patient. You're going to introduce this and you're going to aspirate approximately 5 cc's. And you're going to prepare this to create a wheel where you're going to introduce your needle. Okay? So while you have all that ready, you're also going to prepare your catheter. You may also need a nurse to assist you because some kits do not have these syringes and they don't have the sterile saline. So what you'll do is you're going to go through each catheter. The triple lumen catheter kits typically have these hubs. You typically will remove all 3 of these, and whatever your hospital uses that's compatible with your infusion pumps and medications, you're going to get those new catheter hubs and you're going to actually use those for placement. What you'll do is you're going to take each one of these catheters and you're going to actually flush and load with saline. And as you do that, you're also going to lock each one of these. There's a blue tab on here which you can see. You're going to lock it, and this is going to prevent any introduction of any air which may cause an air emboli. And I'm going to continue. I did the white first, and now I'm going to do the blue. Okay, so I'm going to lock this one as well. And the one hub that always remains open is, this is your brown hub. And so it's standard in every kit. This brown hub is the one where the guide wire will actually come through. So this one you can simply just leave open because this is going to feed over the guide wire with a technique called Seldinger. So we've got our catheter prepped and ready. And now we're going to go ahead and begin our procedure. So the femoral venous selection is it's a very common location to provide central venous access very quickly. Typically, you may have a patient that's in critical condition requiring immediate access. It's an area that you can actually apply direct pressure if you do cause an arterial puncture, or if the patient is coagulopathic. This is the more preferred site. There are risks with this area, which you can imagine. One is it's at greater risk for developing DVTs. It's at greater risk for infection. And also it's not very comfortable for patients because they're not able to ambulate once this catheter is placed. So typically you want to use this site for your emergency lines, and as well as the reasons I mentioned a few minutes ago. So if you understand the anatomical landmarks, you're going to have the femoral crease here, and you're going to have what's called the femoral triangle, which you can see that's marked here with the marker. Whether you go on the right side or left side, the vascular structures are in the same anatomical sequence. A mnemonic that I use is called navel, and how I remember where my artery and vein are is I apply my mnemonic. So nerve is for N, artery for the A, and then V is for vein, so E and L is extralymphatics. So if I were to identify where my vein is, I would actually take my non-dominant hand and I would palpate where the artery is, and I'm just going right below the femoral crease. And as I palpate my femoral artery, I'm just going medial about 1 centimeter to where I feel the femoral artery. And anatomically, that should be the location where my femoral vein is, and I'm actually going to be going parallel to where I palpate the femoral artery as well as the direction of the femur. So now that I know where my vein is located, I'm going to go ahead and inject 3 to 5 cc's of lidocaine 1% for local anesthesia, just right above. This provides comfort for the patient. I'm going to create a wheel. Okay. And on your kit, you'll have standard needle placement so you do not stick yourself. So you want to use precautions to preventing needle sticks. So remember to be knowledgeable where you place your sharps. And what I'm going to do next is I'm going to take my introducer needle with my slip tip, and I'm going to go ahead and palpate where my femoral artery is. And as I mentioned, I'm going to go approximately 1 centimeter to 1 finger medially to where the artery is palpated. And I'm going to take a 30 to 45 degree angle approach to where I believe the femoral vein is. And as I introduce this, the femoral vein is approximately 1 to 2 centimeters at greatest depth. But also, if you do have a morbidly obese patient, remember, when you're pressing, you may displace adipose tissue, and this may distort exactly where your needle may be, and you may be successful in your first attempt, and when you release the soft tissue, it may actually cause your introducer needle to come out. So you want to be very careful and cognizant of where you're placing this. And as I'm slowly advancing my needle, I'm just advancing the needle and I'm aspirating at the same time. And as you can see, if I don't get it on the first attempt, I'm going to simply pull back to the level of the skin, and then I'm going to slightly move to different positions within the femoral triangle, just medial to the femoral artery. This can be very difficult in your hypotensive patient, as you may not be able to feel the artery, and thus it becomes more of a blind procedure. We're able to determine that we're successfully in the femoral vein by dark venous blood. And one way that you can also determine if you're in the artery or vein is to make sure that there's no pulsation. And what we can do is simply remove this hub, and if there's any pulsation of blood, that's a sign that we may have the introducer needle within the femoral artery. But this looks like dark venous blood, so that tells me that we're successfully cannulated within the femoral vein. And the next step is I'm going to take my guide wire, and with my dominant hand, I've got the tip, I'm going to introduce this through. And you want to do this, and you should not hit any resistance, and it should go very easily, which we have. And then the next step is we're going to remove our needle while we have our guide wire in place. Okay. Be very careful with your sharps. And the next step is I'm going to grab my number 11 scalpel, and I'm going to make a small stab just right where my guide wire is located. While I have my guide wire securely held with my non-dominant hand, I'm going to make a stab. And next step is I'm going to grab my dilator, and I'm going to feed this over my guide wire. And while I continue to hold this, because if you do let go, the guide wire can actually migrate, and that can lead to further complications with this line placement. So now that my dilator is at the skin, I'm going to slowly rotate, and I'm going to go ahead and dilate, and then I'm going to remove. And being careful, because you're going to have some bleeding as you remove your dilator. And the next step is I'm going to go ahead and take my catheter, and we're going to feed this wire through. And as you can see, it will come right through the brown port. And I'm going to hold this very carefully. And as I feed, I'm going to slowly remove my wire as I advance the catheter. And my catheter should go in very easily, which it does. And I'm going to remove my wire. Okay. Once again, I'm going to maintain occluding the hub to prevent any air embolus. And what I'm going to do is I'm going to grab my syringe at this point, and we're going to go ahead and attach this. And we're going to aspirate until we get dark venous blood, and we're going to remove all the air. And I'm going to go ahead and inject the saline. And once the saline is injected, I'll go ahead and lock this at this point. And we'll take our hub that we would use for the adapter for our nurses to attach any fluids or administer medications through. And then I'm going to go ahead and proceed to do that with the other two catheters. So what we'll do is we're going to attach it. We're going to unlock this lock here. And I'm going to aspirate until I get dark venous blood and remove all the air. And then I'm going to inject with the sterile saline. And then I'm going to lock it, remove it, place my adapter. And we'll do it with the last one. And then I'm going to inject to flush it. Oops, I'm going to have to also unlock this, flush it, and then we're going to lock it. Remove our syringe, apply our adapter. So now what we have to do is we have to secure our catheter. So in our kits, you'll also have a hub that's going to help provide support and prevent your central venous catheter from being dislodged. So you simply place the white component over the top and the blue over the white. And now you're going to secure it. And in the kits, there is a silk suture, and you have your needle driver. You're going to go ahead and suture this to the skin with a simple interrupted suture. Being careful not to stick yourself. So you will do this on both sides, and you can actually use your scalpel to cut your suture. We can also suture the distal end of your catheter as well to provide additional support. And our final suture will secure this line. And remember, this line is actually high risk for infection, so typically your critical care physicians will use this for up to a day, and they will proceed to usually replace this with either an internal jugular central venous catheter or a subclavian venous catheter. And as I said, this is a line that is done in emergent situations and patients that may be coagulopathic. As you can see, it's all based upon landmarks. And as I said, it's easy to control any complications that may develop with this with initial insertion. So, and the final step is, now we're going to go ahead and we'll dress this, as we want to prevent any central line associated bloodstream infection. So you want to make sure you get your bio patch, blue side up, and you're simply going to place it right at the base of your catheter. Okay. And then you're going to take your Tegaderm, which is simply placed right over, and your nurses can assist you with this, right over the top here. And they will assist you with dating and timing this so they can actually do daily dressing changes. So this concludes the placement of a central venous catheter in the right femoral vein.